Welcome back to another PCBH Corner. Exciting topic today. As we finish up our fiscal year at Community Health of Central Washington, that means that we get to do the midway kind of data dump for the past 12 months that we're going to be doing on the CFHA listserv. And I always really enjoy writing that up. And one of the things that you shared recently, I think it was on LinkedIn, was the penetration rate that we've been able to have over the past 12 months.
Yeah.
Essentially.
The highest it's ever been.
It's highest it's ever been. So I wanted to, my mind was thinking about, we've talked about data a little bit before. One, we should probably define what a penetration rate is, just for people, just as a reminder, why that might be something that's important. And one of our colleagues said on the LinkedIn post, which I thought was really great, it's about like, can you do a PCBH Corner about how you got there, like how you got to that penetration rate? And then I think that could be a segue into if we talk about other data points, other things that we track as we prelude into the email that will be coming out about our data dump for the past 12 months. So yeah, where does your mind go? One, what is a penetration rate? How would you even define what a penetration rate is?
Yeah, so penetration rate is just basically you put in the denominator how many patients have come in for a medical visit, and then out of that sample of people, how many, and now it goes into the numerator, how many of them saw a BHC? And most of the time they're looking at a 12-month snapshot. We tend to do 12-month rolling because then it gives you that same block amount of time. And so, how many medical patients came in 12 months? And then out of that population, how many of them had a BHC visit? And then you get a percentage. And basically, it's looking at your reach into the medical population.
I like how you said that, reach into the medical population. I like how you said about the 12 months thing too, because I've talked to other PCBH directors about this. Sometimes like, we'll run a penetration rate for the past month or so. And it's tough because one, like it just isn't a big enough snapshot to do. And the one thing that we're trying to get with the penetration rate is, are we seeing like the same people over and over again?
Yeah.
So from a month snapshot, you're gonna almost be like, we're seeing a lot of unique people. It's like, it could be. Are you seeing the same unique people the next month? Or are you seeing a greater amount of people or a different amount of people for the month that follows?
And I have been kind of toying with the idea, and I know that you and I have run those numbers a little bit of sharing almost the last 2 years.
Yeah, I know.
And so I would have to maybe look more into the literature to see what's out there. The 12-month is kind of something that FQHCs use in general. They report on their unique patients because they're looking at how many patients did you serve. So, and that's on an annual basis. So that's just kind of where I landed on that. But the 2 years at least does tell you how much you've reached in the last 2 years, which is a decent pocket of time. I don't think it's too long. But for now, I think we've been sticking pretty strong with the 1 year, but I do think it's important to maybe take a little peek at that 2 year too.
A little fun fact. So it kills me a little bit because, when we had our old EHR, I don't know how many years we had data on that. It would have probably been, I don't know, like 6 or 7 years maybe? Like it was a lot of data that we had, and it was crazy the penetration rates that we were getting. Am I making things up that it was like 50%?
It was 50 to 60% when we went back. I think it was it the whole time? Or
I
was
don't
it
know.
Like 4 or 5 years?
That's what I was thinking too. It might have been like 4 or 5 years. And so when you think about that, is that's really neat that within our community health center that 50 to 60% of people over a 4-year period had a touch with a BHC. That's in a touch meaning a meaningful clinical encounter, with 98% of them being billable. So I think that's a thing that's really, really fascinating. It pains me so much. It pains me so much.
Allergy season.
It's fun times in Yakima, but it pains me so much that we lost that data, that we can't now do like 10 years of it. Now we have to start over because of Epic and whatnot. But I like that. I do like that idea of like, looking at a year, because that just seems like it theoretically makes the most sense. That's what a lot of people report on. And even expanding it to maybe 2 or 3 years, just like what is the reach into the population over a specific time period.
Yeah, and we did a PCBH Corner on the penetration rate. I can't even remember how many corners ago, so maybe we could put that into the notes.
Oh, nice.
Underneath.
I'll make a note of that.
So we should do that. But it's a really important number because, again, there's nothing wrong with seeing patients back, because again in PCBH sometimes that's seen as like anybody who's going to need to come back for more than one visit then needs to somehow do your in-house specialist, or like if you have a blended model, you have your BHCs and then you have your therapist, and anybody who comes in for more than one visit, it's like, oh, well, we got to get them to the therapist or to the outpatient, maybe in a different organization that you have a relationship with. And as we know from all of our myths video, that's not what we're looking to do. And now I'm going to talk out of two sides of my mouth. And if the only patients you're seeing back is the same ones, week after week after week after week, and you're only serving a very small population, again, that's not inherently bad. That just doesn't match with PCBH's goals, which the PCBH goal is looking at Gather. And one of the parts of Gather, first of all, is being a generalist and being accessible. And then the R for routine. So if you are being a generalist and you are accessible to folks, and it is a routine part of care, you're going to want to work with more than 5% of your population, or 7%, or even, 10 or 12%, which actually is a pretty good number. But if you have an established PCBH program that's getting more mature, you're going to want to start pushing that.
Well, I love that. And I think back to, again, I always attribute it to Jody Plaha. I don't know if she's the one that came up with this, but what's the equation for having a high impact? Your effectiveness times your reach. And so this is really looking at the reach part of this, where for sure we want things to be effective and all those different things. But if it's getting, and I just went over this with our interns about this, say you have an intervention that's 90% effective. People that come in and they get that treatment, they get 90% of them, they get better, but you only see one person. It's like, oh, that doesn't have a high impact. And so that's where trying to balancing out that equation, that the penetration rate is a great way of showing we have reach within the community to get the interventions out.
I love how you're saying this. And then of course, not for this PCBH corner, but in general, you want to make sure that you have quality care, because like you're saying, if you have if you have an intervention that doesn't work, or whatever the interaction is doesn't work, and you're giving it to everybody, then you're kind of just wasting a lot of resources.
This is why we go into we don't like this idea of BHCs just being handout machines, or just mild to moderate, or just giving people interventions indiscriminately, because it's like, that probably isn't that effective. That's probably not a really, so you're still not going to, even if you see 100% of the population, but no one gets better, you still don't have any impact within that system.
Yeah, and we would always, Kirk would always tell us be more, do something that nobody else on the team can do, and don't basically be a walking handout. And wasting a lot of time and energy just introducing yourself, or doing meet and greets, or giving your card, or dropping a handout in there, maybe not being a walking handout, but walking in and giving a handout. Again, those things in and of themselves are not bad. It's just not necessarily, we're looking for clinical intervention with PCBH, and you're allowed to have patients back, but you're right, you're constantly balancing. And one of the ways when you're looking at the full picture of hey, is my service working? You're going to be looking at how many warm handoffs, you're going to be looking at visits per day. And another one that you're going to be looking at is penetration rate. And you're not looking at any of these data points in a vacuum.
Correct.
You're looking at them together to tell a story.
So let me ask you this. So one of the things, as we get into maybe the main question that prompted this, was what led to our penetration rate? I think before that, though, a lot of times we get this question of well, what should a penetration rate be? And the one thing that I think is really important, my mind thinks is really important to say, is that we don't know. I think there hasn't been a research study. There hasn't been. Kirk hypothesized that a mature PCBH program, what was it, 20 to 25%?
20%.
20% would be kind of a mature PCBH program. The thing I think that you and I both agree with is that really that number probably is never going to be set. And maybe this is what we'll go into a little bit more about how we've achieved our penetration rate. And now almost the efforts that we've been able to make to get to the penetration that we've gotten right now also lets us know that penetration rate is not a success. We could do more, and we should be doing more.
So you're saying that just because we hit 20% or 25%, or we get more BHCs than we hit 30%, that alone doesn't mean full-on success. That is just another data point. And and one of the ones, and I know I talked about it on the PCBH corner where we went over specifically about penetration rate. We were saying, lost my train of thought.
It will come back to, because that's where I think because what we've seen now is that we have 2 clinics within our system. So CHCW wide, in our 5 clinics, our penetration rate is about 26.6%.
Okay.
So over one out of every 4 patients are seeing a BHC that have seen a medical provider in the past year.
I remember what I was going to say.
Go ahead.
That I always want our penetration rate to be higher than whatever the percentage in your population that they're seeing outpatient.
I agree completely.
So if 8% of people see outpatient services, then I'm always aiming for more than 8% because you're just thinking, how can I get more people access to the service? So that's what I was going to say.
I think that's a really, really great baseline to be shooting for, right? Like if we're matching that or underneath that, that's a question of like, are we doing what we want to do with integrated care, which is, reduce barriers, get people access, give people more in. So I really like that how you said that. The other thing that comes up oftentimes, as you were saying that my mind went to, sometimes people say it's like, well, should the penetration rate almost match what the behavioral health and mental health condition rate is, or prevalence rate, which hovers around like 22 to 25%. Now the difficulty with that is, as we have said before, is that one, we're not big on allowing diagnosis to kind of like guide our behavior. Within that, though, is that also leaves out doing preventative care. That also leaves out working with people with chronic conditions. That leaves out. So that's where this ability to really define what a penetration rate should be probably is not going to be possible in a lot of ways. It really is going to be reflective of the context that you're working with, the team that you have, the structure that you have, and almost like a process goal, like almost like something that is like reflecting the process a little bit more, that probably should not be the same year to year. It probably should change what our goal is as far as the penetration rate.
And what were you saying about the 26%?
So 26.6% of the entire CHCW population.
Okay.
Now, what you posted that I think got a lot of people excited and thinking about, at our mothership clinic at Central Washington Family Medicine, we're at 33.5%.
Yeah, I think at the time I posted it was 33%, but we're already up to 34%.
Yeah, so 34%. So 1 out of every 3 patients that saw a medical provider in the past year has also seen a BHC.
Right.
Yeah. So let's start with that. Where does your mind go as far as what allowed us to get to a penetration rate where 1 out of every 3 patients that saw a PCP also saw a BHC in the past year?
And I had joked with you beforehand in person, and then I joked on the LinkedIn post to Laura, shout out to you, that underneath it was like, hey, what would be really good is to know how. And I was like, PCBH Corner ? And I responded something along the lines of like, that's what PCBH Corner is 100 or 1 to 103 or 102 were about. And, it was kind of being, facetious or something, trying to be funny. But some of it was kind of like true. That this isn't just like a goal that you set out to do, and then like it's almost like weight loss. And I don't even like using weight loss. Maybe let's just say getting in shape.
Okay.
It's like getting in shape, and somebody saying, "What did you do to get in shape?" And it's like, well, I just did a lot of consistent behaviors on a daily basis over a long period of time, and was extremely consistent. And then when I got to the point where I was starting to get in a little bit better shape, I pushed it a smidge more, did that for a little while, and then I pushed it a smidge more. And it was really, it's that time and consistency that did it, because it's like, well, how did we get to 33.5%? It's like, and then I kind of started breaking down in my head all the things that we do. It's like, well, you got to sit in the pods and you got to hire enough of them. But the only way you can hire BHCs is if you take care of your current BHCs. And the only way you can take care of your current BHCs is if they feel respected. Well, the only way they can be, so it just keeps going on and on and on.
Well, your point, I think, is so well taken. This is what we always say the data should be. Data should not be goals. Like, I would very much caution anybody for saying, hey, our goal, I'm not saying not to have goals like shoot for and stuff like that, but like from the very beginning, okay, our goal is 13% penetration rate. That's becoming almost like what we don't like about PCBH sometimes, where it becomes prescriptive versus descriptive.
Okay.
It should be a reflection of what we're doing rather than being the direction of what we're doing in a sense. So I love how you're saying this, because what has allowed us to have it be 33.5%, and what has now allowed us to be like, well, 33.5%, that's not the end. Like now we're thinking it should be 40%.
Right.
We want to be moving this more. Is all the little things that consistently are done every single day that creates that context where that number is reflected there.
And I see what you're saying about the goals, and I know that could be confusing. And then I'm like going through my mind about all the trainings I've had on like OKRs and all those different, you know.
And again, I have up on you can't see it, I have up on here, like we set goals every single year about what we want penetration rate to be and different things like that.
So just to use the verbiage to not, you know, confuse anybody, you can put that your result that you want is 13% penetration. But when you break it down into the actionable, like the goals that you're going to do, the goal would be to sit in the medical pods, make notes that are very easily readable, be extremely accessible, do
not miss handoffs.
Yeah, the 60-second rule. We used to call 3-minute rule, but it's more like 60 seconds with responding to a handoff and when you're going to be there with your very specific ETA. It's getting upskilled to where any behavioral influence problem you can help serve the medical team. So then that's where you're breaking it down and saying what you're actually doing, and then what is that the difference between a process goal and an outcome.
Yeah.
So
that's a great point. And you know what's interesting too is that I'm thinking about in Sarah Ortner and Dr. Brooke Stedman, they did a presentation this past year at CFHA about pairing. And that's been a new iteration that we've seen. And undoubtedly pairing has been something that has allowed our penetration rate to go up and up over this past year or two. And we have two people that pair now, right? We have Dr. Stedman and Sarah, and we have Dr. Cook and Lacey that pair together. And that basically just meaning that the PCP and the BHC, they see every single person together on the PCP schedule. So that's a lot of unique patients.
And just for verbiage, when we say together, it actually is separate, but the PCP has their schedule and it has all the patients on the schedule for their day. And then the BHC will see every one of the PCP's patients. And most of the time it works out. We are an FQHC, so that helps a little bit. And I think they've been averaging about 15 or 16 out of the 20 patients that are seen get seen by BHC.
And so that's something we should probably do a PCBH Corner on the pair. Maybe we could have Stedman and Cook and Lacey and Sarah on that. That would actually be pretty cool. So either way, the point though is that behavior undoubtedly has led to a higher penetration rate. However, I would not say to someone, do pairing as an intervention to get a higher penetration rate. Pairing has been produced because of all the different things that we've been able to do that has preceded pairing. The context essentially has now been ripe for allowing pairing to happen. So if someone was starting like a new program or something like that, I wouldn't say it's like, they're like, oh, you know what, Beachy and Bauman, they said pairing really allowed their penetration rate to jump. So why don't we pair at the beginning? It's like, man, I don't know. Pairing only makes sense right now because of the context that preceded it was established.
So let me ask you this. So if you're watching this PCBH Corner and we are saying the things that you can do, and then we're saying like, well, don't just go do them, make the context right. So what are those elements?
Yeah, like almost like the foundation ones, the basic ones. I mean, one is what we've always said, again, well, one trick ponies about this is that you have to understand primary care, you have to understand gather, the 4 C's, high quality primary care. That knowledge base and understanding, and not just understanding it, I was talking to the new PCBH interns about this last week, is having a true belief in those concepts. You can understand something, but then not necessarily believe it. Yeah. And so if you don't believe it, your behavior will ripple out to show that it's like, well, I'm not really bought into this. Like,
so if you don't actually think that you can make the most of a moment and get something important done in one snapshot of time, now they might choose to come back. But if you don't fundamentally believe that you can get something important done in 12 minutes, like we've had on a bunch of other corners, you're not going to hunt that handoff down.
If you don't believe that, hey, we should be generalists, if you don't believe that we should really highlight and believe that accessibility is paramount, that we need to get people in, that this is why we can't have someone leave the clinic because we understand that that person's probably not going to come back. We need to reinforce that behavior. This is where if we're not focusing on the team aspect and really trying to support our PCPs, and it's like, well, maybe I'll get to that handoff, maybe I'll check in with the PCP, but that's not really needed. All those beliefs are going to ripple out to this behavior. So I think the most foundational thing is having an understanding of primary care and then believing in primary care.
And then having that dictate your behavior. So again, just to make things a little bit more pragmatic, I had 2 recent examples from being in clinic not yesterday, the day before, that I think really highlight what we're talking about when what Dave's talking about when he says having a belief in primary care and understanding it. So the one was there was a patient, and I actually was a little bit slow to answer the handoff because two teams came in like right back to back, and I don't know if my brain I didn't hear the ding.
Like short circuit.
Yeah, like you thought that you answered it, but then there was this other one. So I was, instead of responding in, we say 3 minutes or less, it was about 4 minutes. And that's how late I was, which I needed to tell our team, you can at me. If I don't respond, man, you gotta at me. Like, call me
blow
up.
me up. Yeah.
And so I saw this.
We're going to blow you up. Yeah, no doubt.
And it was a very interesting situation. It was 3:17. My 3:15 had just checked in. And the handoff, I was 4 minutes late answering it. So it must have come in at 3:13, but I didn't see it till 3:17. And everybody basically was 20 minutes out. And so I knew my 3:15, and her and I have a great relationship. You know, she's done walk-ins before. She knows that I will make sure I see her. So I'm like, she's going to be all right. So I respond again 4 minutes later than I wanted to, and saying, hey, I will be there. They responded back. The MA said, hey, so sorry. She said that she has to go because her ride is here. Now, it literally just happened. Now, the way our clinic is set up, they're going to have to walk out. They're going to have to check out. There can be a line. Like, there's still a chance. There's still a chance they're in this building. What I could have done was say, well, hey, they had a ride. In my 3:15's here, I don't want to make them late, and I don't want to make them late. But in that moment, I know that sometimes it's hard to ask for help. It's hard to accept help. In the same way, sometimes we're really busy and we want to kind of get out of a handoff, not because we don't want to see the patient, but because we probably actually are waiting on another patient. Patients also kind of want to get out of it. It's scary to talk to a BHC, not because of we're scary, but it's just a newer concept. And it's not as normalized in the medical system yet. And so I just literally pictured it all happening like a flash. Her thinking, yeah, I really don't think I want to wait much longer. And you know what? My ride is here. And it was true. Her ride was waiting for her. So I said to the MA, I said, hey, what's their name? And so she told me, she's like, yeah, she's wearing a whatever. And so I was like, okay. So I walk out, and sure enough, I see a person wearing exactly what she was described, and it was like very obvious. And I'm like, I gotta go offer this. So I walked up to her and I said, hey, I know this is weird, but were you just waiting for a BHC? And they were like, yeah. I was like, well, I'm actually that BHC. I was a little late responding. And I was like, I know that you're waiting for your ride. And she stopped me and she's like, no, it's okay. And I said, well, I can see you now. And she goes, oh, you can see me now? I thought it was going to be 20 minutes. I said, no, it was me. I was late responding. And I was like, we can do it now. And she's like, okay. So the MA or the reception saw this and checked her in on my schedule. And she's like, you're all checked in. You're good to go. We went, did the visit. 20 minutes, and I told her when I said, yeah, we've been pretty busy today. Our visits, can take anywhere between 15 and 30 minutes. We probably have 15 to 20 minutes right now. And anyways, we were able to get something done. And 20 minutes later, she was gone. I had told the front desk through Teams to tell my 3:15 I was going to be late. So everybody was seen. But the only way that happens, and that's just one example of behaviors, like you don't accept the premise.
That is where, one, we need to send a gratitude to that reception person that just was doing that naturally. That shows, again, that's a reflection of values. That's a reflection of beliefs. I think that's the thing that is really tough, and it can be confusing, I think, for directors and other BHCs, because we talk about these behaviors and these different things. The truth of the matter is, like, how would you even define what that behavior is, right? Like, if you don't believe in primary care and the importance of getting people in the moment, accessibility, reinforcing providers for getting handoffs and stuff, you don't go up to that person and be like, hey, we can meet, like we can still do this. So that right there, and that leads to a higher penetration rate, right? Like that's another unique patient that is now served within it. Martine, one of our fellows, was telling me, it was really funny, similar situation. The patient actually did need to leave and stuff. And because I was like, oh, thanks for grabbing that late handoff. She was like, yeah, you know what? They only had like 5 or 7 minutes and we did the visit in 5 or 7 minutes. And what she was reflecting was, I'm still going to make this moment worth something.
Yeah.
Not talking out of it, not believing, like all these different things that we've talked about in past PCBH corners, that moments are not based on time. They're based on interactions. They're based on just the moment that's happening there. that is going to lead to a higher penetration rate. Because if you don't, if that patient that you saw left, or if Martine's patient left, one, that doesn't go into the penetration rate until we complete a visit with them. That means they have to come back. What's the chances of them coming back? Yeah.
Well, that's what I was going to say. It's just like, it is everything being synthesized in a moment. Just like any skill set. In the beginning, you're like, I'm going to do this, I'm going to do that. And then you do it enough times, and then it's just automatic. At that moment, if we break down what I was thinking was, I know that if somebody leaves, the chances that they're going to come back are so slim. I know that if she was ready in this moment, maybe like stage of change wise, that we might have missed the moment. So even if she did come back, the next time she comes back, she might be like, oh no, I'm doing fine.
Yep.
So I know that. So that's like swarming in my brain.
Well, think about for the PCP, and sorry for interrupting you, think about the PCP that worked to get that patient bought in.
Say that.
Oh, were you going to say that?
That was going to be my next one. Is like that MA. I was actually thinking MA and the PCP. They go through all that trouble to get a handoff, and then we can't do it. But now they know, like, hey, no, actually, I saw that person, so that's reinforcing. So all these things are happening at once, and it's crazy because it would have been easier for me just to get the 3:15. I wouldn't have made the 3:15 late, and it would have been a very productive, good clinic. I still saw a bunch of patients, but it was such a good visit with her.
Yep.
And you know what it did for me? It reinforced me.
Well said.
That I don't ever want to miss those handoffs. And it sounds like for Martine,
same thing.
That it was a late handoff. So then you're thinking, oh man, I want to go home or whatever. And they only had 5 to 7 minutes. But it was a worthwhile experience, not just for the patient, but for Martine. It was a worthwhile experience for me. The patient was like, this was so, thank you so much. And she was so appreciative. And we had a really cool moment. I just got chills. We had a really cool moment. So that reinforces me. The next time something like this happens, you're looking at your schedule, and I get it. It's overwhelming. It's scary. You don't want to make people late. But that, if that person who's waiting for you has already worked with you, they know you're good for it.
So that's where penetration rate, which I think is a great data point, and it's one of our big 6 that we track.
Great outcome measurement.
It's a great outcome measure. It is, though, an outcome of the context that's being said. I mean, this goes back to us talking about chefs versus cooks, that I would never want to try to promote this as an ingredient that, hey, put a penetration rate in of 26% to your system and things are going to really be produced. It's like, no. Like, it is going to be a result of you being a chef that's going to produce a really great 6-course meal, going back to, and one of them is going to be an incredible penetration rate. That is a result of those things.
I was going to say, you also have to look at your staffing.
Correct.
Because if you have one BHC in this huge system of medical providers, you might actually be doing a disservice to say, well, CHCW has a 26% overall and 33% at the main clinic. Yeah. Have you seen how many BHCs we have?
And the truth of the matter is, it's like, with the many BHCs, this is where we go, with the many BHCs that we have, maybe it should be higher. That's the thing. It's like, man, that's a really great point, because one of the things I wrote down is the gap versus gain. What's one of our favorite things that we love to do when we look at like Facebook memories, and it's like from 6 or 7 years ago?
Yeah. Was that what it is? I mean, we read those memories, and it's like, on this day, we had this many visits, and then you're comparing it to now.
I remember when we were so proud of an 18% penetration rate. I remember that was like a really, really big deal. Here's the thing that's interesting about it, and I'm not saying this is true, but it could be true. That 18% could be more impressive than our 33.6%.
Yeah.
Because of how many BHCs we had when we got 18% versus how many BHCs that we have when we have 33.6%.
I know, or it could be less impressive, because if we stayed at that rate, maybe, I'm not sure because we don't know, if we would have stayed and kept pushing everybody, they would have felt the burden of like, it's just me and 2 other BHCs and we're doing all of this work and we don't have enough teammates. They might start looking for another job. So you're constantly, as a director, you're constantly balancing pushing yourself, pushing your team. Not that you have to push your team, but we're all pushing each other to take care of the population, but it has to be at a sustainable level.
Absolutely. That's a really, really...
So that's a whole other thing, is like longevity, and I've been wanting to make another PCBH Corner, but Dave won't let me do that. No, I'm kidding. There's a PCBH Corner that I want to do on looking at a mature PCBH program. What do you do when you get out of startup phase? Because there's so many things that we're talking about on all the listservs and everywhere is startup, and that's great. We need to have all these startups. But what about maintenance phase? What about a program that's been mature now? We've been around in like a pretty decent way in terms of staffing and actually like department or service line for about 11 years now.
Yeah.
Maybe 10 years. So what do you do then? Do you do all the same strategies that you did during startup?
Correct. I couldn't. We've talked about. I think it would be a great PCBH Corner, just like even from leadership, right? I think one of the things that's really challenging, I'll speak for myself, is that I think I'm a pretty decent leader for startups. It's like, oh man, being in a maintenance phase, that's a completely different skill set for leadership, and we should talk about that as well. Is like, what does that mean for PCBH as far as like, what contingencies now are shaping our behavior, and do we do the same behavior that we used to do? Is it serving the same function that it used to? And
that's why this is so difficult. And that's why, we kind of like chuckled. And again, Laura, thank you so much for shouting that out on LinkedIn of just like, well, how? It's like, I actually don't know. I actually don't know. I just know that it's these consistent behaviors, just like how does one get in shape? It's like they walk every day. They jog every day or 6 days out of a week so then they can rest a little bit, or you incorporate a little bit of weight training. In this situation is you show up, like our last corner we said that the it factor was just being there for your medical team and being clear for when you're going to be there and taking the handoffs. So that's a really big foundational ingredient. And then you mix in having a really good employee engagement and really tripling down on making sure that your employees feel heard and seen and appreciated. So now they go and they tell their other colleagues, and now you bring more people into your system. So now you have more staffing. And then because you have more staffing, then everyone is shouldering the burden a little bit better. Well, now they're like, this is a great place to work. And now they can come in the clinic feeling pumped up to take all these handoffs.
It ripples in so many different ways. And I think that's the point that maybe my mind will end with. I'd love to know your final thoughts on this, is that penetration rate, unquestionably, a good thing to track. It's one of our big six as far as metrics that we go. It's something that should be tracked. It's something
I like that, the big six.
Yeah, that's something that we should be tracking. It is descriptive, though, not prescriptive. There could be, and again, we've had systems like this when maybe we're consulting or working with, and they tell us how many BHCs they are, and then they actually have the penetration rate. And we're like, oh, that's a pretty good damn penetration rate for the amount of BHCs and stuff that you have. Like, that's actually really impressive. Now, is it 33.6%? No. And that doesn't mean, that's where it's like, even a 33.6% penetration rate, I don't know if that's good or bad. That could be a really cool thing. That could be an impressive thing. But until it's put into a context that it's reflecting that number, we don't know if that's a good thing or a bad thing. It maybe should be higher. And a penetration rate of 8 or 10%, while it might be lower than 33.6, that could be an incredible penetration rate.
That's true.
For someone that might be a solo BHC, or maybe it's a startup, they're really trying to get, like, all these different things. Penetration rate is not prescriptive. It should be descriptive.
Yeah, I think on this final thoughts is just monitoring as you're adding more BHCs, you should see that number increasing. Now, we don't have the exact science on, well, how much should it, and then it's a dynamic system, because what if you lose medical provider? I mean, there's just so many things that
100%.
So many things that can happen. And I think it's pretty safe to say, as you're adding BHCs, you're looking for that number to increase. And I believe that every year for the last 11 years, our penetration rate has...
The only time that it didn't, it was 1 year that it didn't.
2020?
2020.
But it stayed
relatively the same.
Stable.
Yeah.
So in that case, it was actually a huge win.
Right.
That it stayed stable in 2020.
Context. Again, context is shaping these different things.
So yeah, again, the final thought for me is that it's daily, consistent practices and behaviors that are born out of an understanding and a belief. And when you do those things over and over again, Quentin Studer will talk about the flywheel start spinning, and a lot of personal development and other books will talk about the big mo, which is momentum. Then it's way harder to get things started, but once you get things started, and then it can build on itself. And so that's what in the beginning, in the startup phase, you're doing all these foundational behaviors to get it going. And then after that, it's hunting the person down in the whatever color dress, and it's like, oh, they're still in the building. It's saying, oh, we got 5, I have to leave in 5 to 7 minutes, saying, okay,
we'll still see
then let's get done what we can do. And then that makes up the 1 point whatever percent that's not billable, but you still had a meaningful clinical encounter.
And that's where I could not agree more. And I love you saying that. And, you know, maybe in a year from now, I'm excited when we do another data dump, and, you know, who knows what the penetration rate will be. I definitely know now 33.6%, where 5-6 years ago, I would have been like, oh, we made it. At 33.6%, now it's like, oh, I think it could be higher, right? Because again, the context of that, and I love how you said, it's almost kind of, you know, not a grand kind of like intimate, like how did you get to 33.6%? It's like, you believe in primary care, you shape your behaviors to support primary care, engagement with employees, all these different things. Like, as you said, all the previous 100 plus PCBH Corners. That's
so sorry, I didn't mean to like not be straightforward, but there's just not a.
I don't think it's a bad thing to, you know, because again, this one of the reasons why we do these PCBH Corners is we try to be as real as possible about this stuff. And one of the things we don't like is when PCBHs get set up as like, just do these simple behaviors and everything works out.
And if we had a straightforward answer, we would have provided that, I promise.
100%, 100%. Well, as always, let us know where your thoughts are. Let us know if you all are tracking penetration rate and any numbers that are out there. We love hearing them. And then obviously wherever your mind goes. Anything else, Bridge?
No.
As always, we appreciate you stopping by.